Hey, you want to learn how to perform minimally invasive hammer-toe osteotomies without the fear of making mistakes? I'm a podiatrist specializing in MIS, and I've also helped hundreds of colleagues at the various cadaver lab events with incredible results. Let's dive in. Yeah, I've hosted over 35 private group cadaver lab events and then big annual MIS events for past 5 years. And what I found was very intriguing. I found that doctors who focused on only a few MIS procedures, they're the ones who produced incredible results in less than 6 months. However, doctors who try to learn everything, like first event, they try to learn hammer-toe exostectomy, first metatarsal osteotomy, lesser metatarsal osteotomy, middle foot, calcaneal osteotomy, it's too much. For those who focus on everything and try to learn everything, they're the ones I found out later that overwhelmed and then putting things off, not doing pretty much anything. Even after 6 months, after even few years, I see these colleagues at the various events and I ask them, hey, have you been performing now? Unfortunately, they say, no, I'm not ready. I'm going to wait until this is done. I'm going to wait that is done. It's paralysis, right? Paralysis by analysis. Focus on a few things that will help you deliver the results in less than 6 months, especially in MIS. This leads to point one. So key point one, core MIS foundation principle. So I just talked about focusing on a few things. So let's focus on hammer toe. Don't think about, bunion, osteotomy or calcaneal osteotomy. Right now, just focus on hammer toe. But this core foundation MIS principles applies to every MIS procedures. This is what the core MIS principle is. Incision, prep, bone work, splinting. I'll say that again. Incision, prep, bone work, splinting. To quickly go over these 4 steps, you have to make incisions. MIS is not typical linear incision. You make like a poke or like stab incision to get to where you're going to do bone work. Depending on procedures, what kind of incision portal you use, location of the incisions, of course, that's important. Step 2, prep. What do I mean by prep? After you make the incision, you create a portal, so you got to use elevator or different kind of micro rasp to prep the area where you're going to do the osteotomy. And step 3, bone work. That's where you do osteotomy or reduce the bony eminence. That's where you do typical MIS bone work to correct the deformity. Then 4th step is splinting. Bandaging and splinting is as important as MIS procedure itself. Why? Because splinting, external splinting, that's our way of fixating the osteotomies. So without learning how to splint properly, you may have done really beautiful MIS osteotomies, but outcome may not be satisfactory because if you don't know how to splint them so that stabilize the osteotomy, it may result in bad outcome. Before I move to the next key point, don't forget to subscribe to my YouTube channel so you don't miss out my other contents that will help you grow your practice. Key point number 2, MIS hammer toe on diagram. Let's focus back on hammer toe. I'm going to show you how I do osteotomies on hammer toes, but for you to understand that, I believe this is very beneficial for you to see the actual diagram. Traditional open hammer toe procedures, typically surgeons destroy the joints, arthroplasties, right? So either you take the head of proximal phalanx and then fixate, typically requires some sort of fixation, like using pins, wires, or implant. But how I do MIS techniques, we don't go for joints. Instead, you create either plantar flexory or dorsiflexory wedge osteotomies at the diaphyseal region. Quick tip, why diaphyseal region? Because those have better blood supply and also it is located inside of intercapsular region so that it becomes more stable cut to heal post-operatively. So let me show you the diagram how we do minimally invasive osteotomies in the hammertoe deformities. Minimally invasive surgery, we try to salvage the joint rather than destroying the joint. So if I may draw a quick diagram of hammertoe in a lateral view. This is metatarsal head, proximal phalanx, middle phalanx, and then distal phalanx. And then you're looking at the side view basically, hammertoe deformity here. And then do the bone cut. Instead of we taking the head out, typical approach is to create plantar flexural osteotomy at the base of proximal phalanx. So imagine if we do that, it's gonna, like this, when we make a base osteotomy, it's gonna drop down. And then when it's dropped down, you're gonna do middle phalanx osteotomy to dorsiflexural wedge so that it's gonna drop and then dorsiflexural wedge at the middle phalanx and then lift the tip up. Now, in order for you to do that, the base osteotomy of proximal phalanx, we can do two ways, and I'm going to demonstrate that in the sawbone. Key point number 3, sawbone demonstration for hammertoe osteotomies. There are many ways to approach osteotomies for hammertoe. How I do, I mainly use two approaches, dorsal approach or plantar approaches. I keep saying you gotta make it simple. More complex you make your MIS procedures, it will give you stress on every case. So what I'm helping my clients is to keep it simple, systemize, and rinse and repeat. This way you can give your 100% focus on procedure itself, not all the other things. Oh, what if I do this? Oh, I wonder about this. That's too much for you to focus on your procedure at hand. So make it simpler, right? I would like to show you the plantar approach for hammertoe osteotomy. This approach has been published and performed by hundreds, if not thousands, of foot and ankle surgeons all around the world. It does have a bit of a steep learning curve at the beginning. Due to the angle and direction of this approach, that you may not be familiar with. Quick side note, due to this steep learning curve on MIS procedures in general, I put the description below if you want to learn more about my MIS mentorship program, how I can deliver results to all of my clients completing my program within 6 months, and then they get to implement 3 most important and frequent, less complex MIS procedures in less than 6 months. So let me show you this quick clip to demonstrate how the osteotomy was performed from the plantar approach at the base of proximal phalanx. If you don't mind showing this on the sideways, this is the OSADA drill. So you turn on, turn on, turn on, turn off, and then side pedal, it makes rotating the drill. Of course, you don't go too fast. But all the details I teach you guys in a systemic manner in our MIFAS Accelerator course. But for this video, I'm going to show you the first way I just told you about going the bottom plantar approach. It goes from, so I'll demonstrate that cut on the second digit here. From the bottom of the foot, and then you make an incision and create a portal next to it, and then you're basically a little sawing motion, carousel motion from cutting one side to the other side. It takes more learning curve, but then second way I'm going to share with you, I believe is simpler for you, but anyway, this is the first way. So I'll start the drill, assuming this is the bottom of the foot, and you go here, right at the fringe, at the base, and then you go in and out, like this, carousel motion. You can do close up too if you want, and basically non-dominant hand putting pressure to plantar flex this the dorsiflex toe, right? Like so. Very quiet motion. And if you see, I just create the wedge cut. Wedge is created by non-dominant hand motion, and then it'll drop. You see how toe drops, so that we create a plantar flexory wedge at the bottom, and then this toe can be dropped like so. So it takes a little bit more learning curve because you're coming from this angle, patient's laying down, and then you're looking at from plantar approach, and then it's like slight movement of this part will create, instead of where you want to cut, because remember, you're not seeing it, you're feeling it, so that if you drop it, then you will cut more distal shaft rather than the base. So you have to constantly put this same level throughout the cut. So that's the most difficult part for for you to start hammertoe procedure osteotomy in a plantar approach. The second approach is dorsal approach. You're looking down. Let me show you the Sawbone again. You're looking down and then making osteotomy at the same level, base of proximal phalanx. So it still takes a bit of learning curve, but it's kind of more logical to many doctors I've talked to, that they feel more natural. However, again, as I showed you in the quick video, the standard approach is a plantar approach. But again, both dorsal and plantar approach produces great results on hundreds of thousands of patients. And if you equip both ways, even more than both ways, but again, keep it simple. If you know two ways, this will equip yourself with a great skill set, and you'll be able to help hundreds of thousands of patients. Again, look at the description below if you want to learn more about my MIS mentorship program so you can implement MIS procedures in less than 6 months. Now you know how to make hammertoe osteotomies using MIS techniques. But if you want to learn what kind of surgical blades I use for this type of procedures, watch this video and I will share with you what type of MIS surgical blades I use for my procedures.